Melissa Sweet here, public health journalist reporting from the National Rural Health Conference in Cairns. We've just come out of a fantastic session with Dr Jonathan Sher, and I'm very pleased he's making time available to chat to us now. He had the audience very interested and engaged. It was a fantastic example of content that matters and presentation that engages. So Jonathan, you started the presentation with a little bit of a joke, I guess. What's the difference between Las Vegas and early childhood? Can you tell us why you began that way?
Sure, because...
And then also a little bit about who you are, too.
Yeah, well, if you ask somebody what's the difference between Las Vegas and early childhood, it captures their imagination because it's not a question they've ever been asked before. And I ask it to make a point, and the answer for me to that question is what happens in Vegas stays in Vegas. But what happens in early childhood never just stays in early childhood. And I think it's a way of reminding people of something they already know, which is that those early experiences, some of which we don't even consciously recall, are the ones that shape us for the rest of our lives, and sometimes, unfortunately, misshape us. But as somebody who's concerned about the next generation of mothers and fathers, what I wanted to do was make the point that the beginning of parent education is in fact how we are ourselves parented. That creates the template. That creates the default setting in our brains about what parenting is like. And if that's good, we tend to emulate it. If it was bad, then we will become fiercely determined to not repeat the harsh experiences we had growing up. So that's where parent education starts, and my point is that preconception, health, education, and care is across the life course, starting with our own births, continuing through childhood and adolescence. It's not just about the few months before actually becoming pregnant.
You made a very powerful point about the language we use around closing the gap. How does this area focusing on preconception and the very earliest times of life, why does that matter in terms of that language?
Well, for me, it's absolutely fascinating that on 3 continents that I'm aware of and where I work, that the language of close the gap has become the catchphrase, the priority, the goal. And should we close gaps in education attainment, in health status, in overall income and well-being? Of course we should close the gap. Of course that's the right thing to do, and governments and organizations are on the right track when they pursue it. However, that said, wouldn't it be better if instead of waiting around until the gaps had to be closed, that we took the actions necessary to keep those gaps from ever opening in the first place? And so most of my work is about primary prevention. What can we do to prevent harm, to prevent bad things from ever occurring, from getting started? What can we do to nip it in the bud, or not even have the bud that you need to nip? And so for me, preconception, health, education, and care across the life course is where primary prevention starts. It is the cheaper, more effective, better alternative to waiting around to close gaps that might never have existed if we'd paid attention, been awake, and took effective action much earlier.
What is the evidence around intervention at that time, and what sort of interventions are we talking about?
Well, there is no age at which doing something good for another person is the wrong thing. That's true at any age. But there are some boats which have already sailed if we wait too long. And a great example on which Australia has taken action is, and the UK has not, is fortification of the food supply with folic acid. And what that's been shown internationally, there's an extensive research base that says that 70% or more of neural tube defects can be prevented by having adequate folic acid, which you don't get naturally, in the 3 months before pregnancy and the first month of pregnancy. And the crucial part about that is that neural tubes isn't something that comes up over dinner conversations, but this is a neural tube is the embryonic part of what becomes our brain and our nervous system. Those are sort of important. And if they are defective, it's not just that some children are born with neural tube defects and have spina bifida or other related problems. It's that many stillbirths and many miscarriages are caused when the body itself realizes, oh, a neural tube defect, this isn't a viable pregnancy, and the pregnancy ends before a live birth. It's heartbreaking still in the UK for obstetricians and midwives and GPs to have women who are in their second or third month come in for their first visit and say, I've heard something about folic acid. Should I start taking that now? And it breaks their heart because it's too late. If it doesn't happen at the preconception level, if it doesn't happen in the months prior to pregnancy, the neural tube defects cannot be prevented. And so I think it's a sort of classic example. And there are 79 other countries besides Australia who sensibly have fortified this food supply. The UK is not there yet, but we're pushing hard, especially in Scotland, to make that happen.
So that's one thing that Australia has done well, taking
Absolutely.
that population-based approach to folic acid, preventing neural defects. Where are some other areas that we might learn from other places? You mentioned a number of programs. Oregon, I think you mentioned it.
Yes,
some other places.
There is a program that began in the States, in the state of Oregon, by the Oregon Foundation for Reproductive Health, and it's called One Key Question. And it is a brilliant and deceptively simple idea, which is that GPs and other health practitioners will regularly ask people of childbearing age, do you want to be pregnant in the next year? And the answers, of course, can be yes, no, not sure, or okay either way. And the magic of the program is the preparation that goes into asking that question, and most important, in then following up on it. So if someone says, no, I don't want to become a parent in the next year, then making sure that effective contraception, usually long-acting reversible contraception, is available is what happens next. And if you came in because you have a sore throat, you wouldn't expect to be asked this. But what they found over and over again is this was created by women, for women for the most part. And women appreciate being asked for the most part. And most of all, they appreciate that there's a follow-up that's meaningful and real. So that contraception, if your answer is no, preconception, health, education, and care, if your answer is yes, not sure, or okay either way. And the context for all of this is that in our nations, in Scotland and the UK and Australia and the US, roughly half of all pregnancies are unplanned, unintended, or mistimed. Now that doesn't always mean that they're unwanted once they happen, but what it does mean is that preconception, health, education, and care is exceedingly difficult if half of the pregnancies weren't intended, weren't planned, or were mistimed.
What difference has the program made? Do we know, or is it just a good idea at this stage?
Well, it has been trialed now in 22 states, and there's not a random controlled trial or other robust evidence of that nature. But both anecdotally and in the evaluations that have been done, what we found is not only that the people who are asked and answer the one key question enjoy the experience, but that it leads to things they value And the initial evidence is that it results in better contraception or in more effective and meaningful preconception care.
You also mentioned some mellow parenting programs. Were they from Scotland? I
Yes,
believe?
although my voice wouldn't reveal it, I live and work and am now Scottish, have been for more than a decade. Mellow parenting is an example of two things. First of all, in its own right, it's a very good program that helps vulnerable mums and dads develop better relationships with their own young children. But what's fascinating to me about it is that although the program worked, the organizers of this said to themselves, you know, this is good, but we ought to be doing this earlier. So they went from mellow parenting to mellow toddlers, not getting rid of the other, but adding. And then they added mellow babies. And then they added mellow bumps and dads-to-be. And now they're piloting what for me is a wonderful program on preconception called Mellow Ready. And they're working with a group of young care leavers to test this out. People who are not yet pregnant, who are not yet parents. Because what's known in Scotland, and I suspect elsewhere around the OECD world, is that care leavers are dramatically more likely to be early parents and unfortunately dramatically more likely to have children who end up in the care system themselves. It's not a happy or healthy situation for anyone, and mellow parenting, especially at the preconception level, is a way of breaking that cycle at last.
What would the program entail for that group? What might it be engaging them in doing?
Well, the crucial thing in any of these programs is to create a sense of agency, a sense of empowerment, that in fact there is such a thing as good health, that and that each person has the capacity to understand the information and use that information to make the best decisions for themselves about such fundamental questions as, do I ever want to become a parent? And if so, when? And with whom? And under what circumstances? And what do I need to do to prepare so that I get the outcome I want? And that kind of work is extraordinarily important and extraordinarily rare. What it speaks to is a universal. Doesn't matter what country you're in, what socioeconomic group you're in. Human beings, if they're going to become parents ever, all want three things. They want a safe pregnancy, a thriving baby, and a rewarding parenthood. That's the good news. We don't have to convince people to want this. They already deeply desire it. The bad news is that too often that's not what in fact happens. They don't get those three things. And for me, the challenge and the opportunity is that most of the reasons they don't get a safe pregnancy, a thriving baby, and a rewarding parenthood are all things that are preventable. But so far, we're not doing as much as we could and should do to really prevent them.
And you made a very powerful point at the end of that session, saying that, you know, it's good to look at programs elsewhere and to think about how you might adapt them, but really look to what you're already doing well and adapt that. Could you elaborate on that message? You know, why?
Oh, absolutely. What we're looking for, what I'm looking for, is an all-hands-on-deck effort. This is not a spectator sport. This is about people working in their own backyards, in their own networks, in their own organizations or professions, and with the others around them, to each do what they can. And so for me, this is not about, well, we've got the answer and you adapt it to your community. It's about people stopping long enough to think, well, what do I do well? And how can I begin to include preconception into my thinking, and most important, into my action. And for me, the crucial slogan is that nobody can do everything, but everybody can do something. to make sure that the next generation of mothers and fathers are better prepared, better supported, and more likely to really get those three things that they deeply desire.
And I think you made the point that all of us have a responsibility. You know, if we do have people in our circle who are intending parents or in that stage, waiting, expectant parents, that we should be doing all we can to support them. We all have that responsibility.
Oh, absolutely. And it is, again, an all-hands-on-deck effort. My goal is not that there's a ministry of preconception health or a department or a new university program. It is extraordinary how much can be done without new legislation, without millions of new dollars, without a whole new training and credentialing regime. It's a matter of people looking at what they do and then saying, what would be an earlier version of this that would be even more effective? Because so many of the problems exist not because they can't be prevented or dealt with earlier, but because we don't even think of it. We live in societies where there are these two big boulders, these two states of being, that either you're avoiding pregnancy or you're pregnant. But between those two big boulders, there's this wee pebble that's preparing for pregnancy. And the wee pebble needs to become the third boulder.
Are you familiar with the first 1,000 Days program in Australia? Professor Kerry Arabina and others are rolling out at present.
I am. In fact, I was part of the group that came up with the 1,001 critical days in the UK. And in Scotland, that went under the name of Social Justice Begins with Babies. And it was, as you know, it's the 1,001 critical days. And it was meant to be a sort of play on Scheherazade and the 1,001 Arabian Nights. So these are the days, and it's been from pregnancy to the age of 2. I understand that in Australia there's some talk of it being the first 2,000 days. My recommendation would be to take several hundred of them before pregnancy instead of just adding them later in childhood.
And this is a nice sort of throw-in, I guess, to telling us a little bit about your story. How have you come to be working in this field? What has been your personal trajectory?
Well, the first half of my now astonishingly long career, I've been working for the past 40 plus years in these fields. But the first half was about rural education, rural community development, working in, with, and for rural, remote, and marginalized communities and people. The latter half of my career has been focused on children's issues, public health, and especially primary prevention. And I don't see those as being stunningly different. What I've done in my own life is to look at the work I was doing on education and to say, wait a minute, there's things that need to happen earlier. So for example, when I was working with schools, there were big debates about whether to use phonics or whole language. And the professionals would have these fierce debates, but what didn't happen was that life for the children didn't actually get better no matter who won. And so that started me thinking, well, what actually would make life better for children? And so I started with primary school and then said, nope, like mellow parenting. I said, nope, needs to be earlier. So preschool, well, no, not quite yet. So in the first 2 years of life, well, yes, those are crucial, but so is pregnancy. And then finally, where I am now is understanding that preconception, health, education, and care across the life course is the place where primary prevention really begins and where it can be cheapest, most effective, and easiest to do. So why not do it?
And that's a fantastic note to end on. Thank you very much.